So Dr. Jackie here. I'm with Progressive Pelvis. We provide pelvic floor PT in the metro Atlanta area. Dr. Jason Lomboy is here today from Advanced Urology. He also serves the metro Atlanta area. He's a board certified urologist, and we have lots of questions for him on the topic of recurrent UTIs.
Yeah.
So Dr. Lomboy, the struggle is real. I know you feel it too, and you get tons of patients in your practice who probably struggle with ongoing UTIs. And so I wanted to ask you, a lot of people wonder what the causes are of recurrent UTIs. So I thought we'd start there.
Yeah, I mean, first of all, I'll just say it's a very difficult topic, primarily because there's such a lack of research. I encourage everybody to, seek advice or counseling from a professional. In terms of, what causes UTIs, first, I think it's important to kind of separate between what's considered to be a complicated UTI and an uncomplicated UTI. Oftentimes when the topic of recurrent UTIs is discussed, it's in regard to uncomplicated UTI. Complicated UTI is when there's a secondary cause, either structural or medical in some way, in which a evaluation with a urologist or a gynecologist or urogynecologist would assess to determine whether there's some underlying source. And once those have been ruled out, generally we would kind of consider this to be uncomplicated, assuming patients aren't, a fever or recurrent kidney infection, something like that. The source of UTIs is generally thought to be that pathogens from either skin flora or fecal matter enter the urethral bladder and cause. So.
Gotcha. Okay. So I think a lot of people, when they come into my office, they want to know, because they've had several in a row, like what can I do to prevent them?
Yeah. So again, I just always kind of say, make sure that you've had an evaluation. These aren't complicated, that there's some underlying source. But if you've had that evaluation, there is an underlying source, these are recurrent, uncomplicated UTIs. There's a lot of different things that people can do. I think the conservative treatments, of course, are very important. Fluid management, limiting bladder irritant, of course, pelvic floor physical therapy. And there are a number of, even medications that we use. A hot topic in urology and infectious disease right now is this topic of the urinary microbiome, that we a set of commensal, organisms on our bodies that actually prevent UTIs. And when we do things that promote a healthy environment, we actually prevent those UTIs. That can be controlled by a number of different factors. Sometimes age related, it can be hormone related, it can be related to, activity, body habitus, stress, medications, other medical problems. So there's really not a one size approach.
Yes, absolutely. So we see patients with who've had a history of recurrent UTIs, and commonly what we find in pelvic floor PT is that because they've experienced so much urgency, burning, pain, sometimes they can have secondary pelvic floor dysfunction, which means ultimately that they've done so much clenching and guarding with their muscles that they develop pelvic floor dysfunction. But we've also seen kind of a primary pelvic floor dysfunction with these patients who present commonly as a UTI-like symptoms, but then when we treat their pelvic floor dysfunction, their symptoms seem to get better. Yeah. So it seems like there's some patients have a primary pelvic floor dysfunction, and then some have a secondary pelvic floor dysfunction. And so that's how in pelvic floor PT we work to help with the symptoms. I get patients who ask me about embedded UTIs. They've heard about this and they're curious, and sometimes they want to put themselves in that bucket. And that's usually when I refer them back to you and say, talk to your doctor, because I know there's some testing that needs to be done to really understand the type of UTI that they might have.
Yeah. I mean, first, to comment on what you said first, I mean, yeah, pelvic floor physical therapy can be very, very, I know you've helped a number of my patients, but you're absolutely right. It can be primary or secondary. Oftentimes, when a patient has, a urinary tract infection, even despite appropriate antibiotic therapy, there can be inflammation surrounding the bladder involving the pelvic floor muscles. And, conversely, they can also report primary bladder dysfunction, which can affect the bladder and urgency and pain, and is primarily treated with pelvic floor therapy. So that's a good thing to know. In terms of embedded UTIs, it's definitely a hot topic in urology, and like I said, in infectious disease. It's not really a term that I think is really recognized by the medical field. The idea behind the embedded UTI is that some bacteria have the ability to form a biofilm that makes them resistant to traditional antibiotic therapy, or make them more common to come back. And it really is a difficult problem for patients and for us. Unfortunately, there's a lot of bad information out there on the internet, just as much as there is good information. So oftentimes, be very skeptical of what you read online. But we are definitely able to help, at least initially with the basic evaluation, to determine, are we dealing with a chronic UTI, recurrent UTI, or an embedded UTI, or is this something else?
Right. Yes. So I know that a PCR test is commonly a test that you guys will run. Now, one of the questions I got was, does a PCR test rule out all UTI possibility?
Yes. I mean, we have to believe it does at this point, and first I'll talk just briefly about PCR. I mean, we, in our office, will do a simple urinalysis, which, if many aren't familiar, it's just a reagent test, and that's what tells us if there's signs of a UTI. And that's a test we can do in 20 to 30 seconds. A urine culture is a test that takes 2 to 3 days, where the urine is grown to see what bacteria grow, and then we treat it with certain antibiotics to see what antibiotics destroy that bacteria. So that's the culture and sensitivity. PCR is really the newest detection of infections, and basically the idea is, PCR stands for polymerase chain reaction, and we're looking for actual DNA of the bacteria, and it's extremely sensitive. We're able to find, of colonies that we wouldn't find in a traditional culture. We can find a lot of different bacteria that wouldn't even be speciated on a normal culture. And we can even find viruses as well. Sometimes I've found either a very atypical bug or even a infection on a PCR. PCR, I had to answer your question emphatically with a yes, just because there is a little asterisk after that. I have read some of the reports that, bacteria may invade the actual bladder cell, and therefore, are unable to be detected by culture PCR. And this is still something that needs to definitely be researched. I would never encourage a bladder biopsy to look for bacteria, but currently, we do believe even with these biofilms, they would show up on a PCR.
Okay, good to know. Now, what if one has a negative test but continues to have symptoms? What would you suggest at that point?
Yeah, so oftentimes when patients see me, they're kind of put into a couple different categories. Either they have positive cultures and no symptoms, and that's the easiest thing we can talk about. They have symptoms with a negative culture, or they have symptoms with recurrent positive cultures. In this situation, where they have symptoms but no positive cultures, as is very common, I would start off with a PCR test. That's going to simply put us at ease that either this is a bacteria or a virus, or it's not. In combination with PCR, we do a couple of other tests in our office that look to, assess how one empties their urine flow. And of course, history and physical is really the mainstay of working up these patients, just because listening to patients, you can hear, what their treatment goals are, and helps me to formulate what their best treatment plan will be. But anytime we see a patient with symptoms and a negative urine culture, we have to consider these other possibilities. And there is a long laundry list of conditions that are in that category. Primary pelvic floor physical therapy, primary pelvic floor dysfunction being one of those that we commonly see and refer to you for. It can be interstitial cystitis, which is another hot topic. It can be overactive bladder sometimes. Incontinence. It can be endometriosis. It could be a bladder stone. It can be, scar tissue from a prior surgery. So there's a lot of different things that can cause symptoms, but not yet have an actual positive culture or PCR.
Cool. Good to know. Now, commonly, antibiotics are prescribed for a UTI. And if the symptoms persist and or the infection persists, what happens then?
Yeah, so I mean, if symptoms persist despite appropriate antibiotic therapy, again, I would repeat a PCR, because that's what's going to tell us, is this a recurrent urinary tract infection, potentially a bacteria that has a biofilm that requires either, some sort of in-depth management of sometimes antibiotic prophylaxis, sometimes just maximizing what we can do to improve the microbiome. In terms of if they have symptoms and the PCR is negative, then we would consider further testing. Cystoscopy is a common test that we do. It's not recommended for everybody that has recurrent infections, but it can shed some light on, what the bladder actually looks like. Is there any signs of inflammation? Interstitial cystitis, as we talked about, is a hot topic, but in itself is a diagnosis of exclusion. And so cystoscopy is helpful. Imaging sometimes is recommended as well. We'll look at the kidneys to make sure that they've, don't have any underlying structural issues or drainage issues. But there's a number of different things that we do in our workup to kind of, once we've ruled out that it's a UTI, to kind of see what else it could be. Yeah,
cool. Okay. I also had a question about, does a prolapse put you at risk for a UTI?
Yeah, so prolapse can. I mean, essentially, that's part of complicated UTI. There's a number of different keywords and symptoms when we take a history and physical that clue us to that. And the evidence of prolapse would suggest there may be an obstruction. Often is the case with pelvic organ prolapse. And so sometimes many patients will see that when they have their prolapse corrected, which we can do through a number of different ways, that their infection risk is reduced. Same goes for patients with overactive bladder and other types of incontinence.
Cool. Now, we're reading more and more research about estrogen and the prevention of UTIs for population that might be menopausal and or even postpartum. Yeah. What do you suggest there? I get a lot of women who maybe come to me and they're like, well, I don't want to do estrogen, and they have some misconceptions about it.
Yeah. I mean, it has amazing evidence that it is very helpful in preventing UTIs in the perimenopausal or postmenopausal patient. Even urologists, have a little bit of a saying that, we've cured more urinary tract infections with estrogen than we have with antibiotics. And that's because that evidence is so robust. The thought behind it is, it obviously increases blood flow to the, that area, the urogenital flora, and kind of maximizes that healthy microbiome that protects against those pathogens. A lot of patients' concerns about estrogen are related to the side effects or complications with estrogen. There is a slight risk of things like blood clots. That's more with estrogen that's administered in other ways. Generally, that is minuscule with a topical estrogen. One thing we always want to rule out is any history of breast cancer, and particularly, ER-positive breast cancer. Those are all things that we assess for when we evaluate a patient.
Cool. So I also have a lot of patients who ask me about supplements for bladder health. Do you have any comments about any of those?
Yeah, I mean, there's not a whole lot of great evidence about a lot of these supplements. Cranberry, D-mannose are some of the more popular ones, and they do have some evidence. It's conflicting on both sides, but I certainly tell patients, it has very little downside, if only to maybe your wallet. But they both, the mechanism of action of these is that the thought is they prevent adherence of the bacteria to the cell wall in the bladder, and prevent these biofilms from being created and being a recurrent problem. Those are often something that a lot of my patients will try. We talked a little bit about estrogen, which is a prescription, but is a supplemental therapy for a lot of patients. Have you heard of any others? I'm happy to. I know there are some companies. I know Ucora has a lot of supplements, and I certainly don't think there's much downside to using those. And when patients tell me they work, absolutely, I encourage them to continue that. It's just from an allopathic standpoint, our scientific evidence is very limited on those.
Yeah, I think the only other two that come to mind in particular are aloe pills, and that's more on the interstitial cystitis side, but also because of moisture helping to kind of wick away bacteria, Reverie being an option, would you say? What would you say about that?
I'm not familiar with
Reverie by Bonafide. It's a vaginal suppository with hyaluronic acid.
Okay, yeah.
It just helps with vaginal moisture.
Yeah, no, I mean, I think both of those things make intuitive sense, and certainly could be beneficial to patients. It's certainly something they could try. I think the medical evidence is lacking, and that's unfortunate. I think that has led to a lot of companies and websites making some of these claims that may not have much scientific basis, and certainly may have led patients to spend a lot of money on certain supplements. But the end goal is that a patient believes, if they believe it helps them, then I encourage them to continue it as long as it's not dangerous.
Yeah, cool. Yeah. Dr. Lomboy, how can patients find you, book with you?
Yeah, so they can visit our website, Advanced Urology. They can send me a message. We're happy to have somebody reach out to them. I will say I have an amazing physician assistant, Caroline Sapersky. So for some female patients that prefer to see a female provider, she is also available and sees just as many, if not more, patients with recurrent UTIs, IC, all of that as well.
Ooh. Well, thank you so much for joining us today. I know a lot of people will be ecstatic to receive this information and kind of have more in their toolbox to help deal with this recurrent UTI issue. So thank you so much for your time.
Yes, thank you, Dr. Jackie, for having me.
All right, take care.
Thanks.